Welcome to KISS Pharm's lecture series on cardiac pharm. We'll start today by talking about the antiarrhythmics. We'll start talking about the class 1 antiarrhythmics, and the first thing we're going to do is talk about the mechanism of action. All class 1 antiarrhythmics work on sodium channels. What channels do they work on? Sodium channels. Fast channels or slow channels? The answer is fast channels, so they work on fast sodium channels. What kind of channels? Fast sodium channels, and by working on these fast sodium channels, what they do is they decrease the conduction velocity of that action potential. They decrease the slope of phase 0. What slope do they decrease? Phase 0. What phase? 0. And they increase the threshold for firing in abnormal pacemaker cells to help get that abnormal firing back to normal firing. Okay? So let's start talking about 1A, 1B, 1C. We'll name all the drugs first, and then we'll talk about each category separately. Now, there's different mnemonics in the book, and all these different mnemonics, they work for different people. I don't like those mnemonics because they don't remind me of rhythm or antiarrhythmics. The one is like a double quarter pounder, French fries, please, and like I said, I don't know them because I don't learn them that way. But I see antiarrhythmics, I think rhythm, I think music, so all mine are music related. So I'm going to give you my mnemonic, and you're going to repeat after me. All right, for class 1A, we have A for ABBA. ABBA, performed dancing queen. Everybody repeat after me, say ABBA, performed dancing queen.
ABBA, performed dancing queen.
Excellent. Class 1A, ABBA, A, performed dancing queen. PDQ for procainamide, disopyramide, and quinidine. And we'll do this again when we do these sections individually. Okay, so class 1A so far, we have performed dancing queen, we have procainamide, disopyramide, and quinidine. Class 1A antiarrhythmics. Class 1B, for 1B, we have the Backstreet Boys. And the Backstreet Boys mainly lack talent. Repeat after me. Backstreet Boys mainly lack talent. Go.
Backstreet Boys mainly lack talent.
I think I want to get sued after this lecture. Class 1B. Backstreet Boys mainly lack talent. Mexilatine, lidocaine, tokenide, and phenytoin goes in that list also, which is not part of the mnemonic. Okay? Phenytoin is considered a class 1B antiarrhythmic as well. All right? And class 1C, and the mnemonic we have for class 1C, there's a reason for it. Okay, C for Carly, Ray Jepsen. So we're going to say Carly is extremely freaking painful. 1C, Carly, extremely freaking painful. Ready? Everybody say Carly is extremely freaking painful. Go.
Carly is extremely freaking painful.
Exactly, and the non-PG version of that too. You can say it at home. Okay? Class 1C antiarrhythmics, Carly is extremely freaking painful. Enconide, flecainide, propafenone. And these drugs actually are extremely freaking painful for your patient. That's why we don't use them that much. So we'll get to those when we talk about them. So class 1A, our mnemonic was ABBA, performed dancing queen. Say it.
ABBA, performed dancing queen.
And the P stands for? Procainamide. And the D stands for? Disopyramide. And the Q stands for? Quinidine. Well, these class 1A antiarrhythmics, the way they work is they increase the duration of the action potential and the effective refractory period, which we'll just call ERP. So they increase the action potential duration and they increase the ERP. So they increase the AP and ERP. They increase the AP and the ERP. What do they increase?
AP and ERP.
Excellent. So in addition to atrial and ventricular arrhythmias, these class 1A antiarrhythmics are really good for re-entry arrhythmias. They're really good for re-entry arrhythmias and for ectopic arrhythmias like SVT. That's not the only one, but ectopic sites of beating is what they're used for, okay? So ectopic, SVT, as well as re-entry arrhythmias, we like these class 1A antiarrhythmics. And the 1A antiarrhythmics, we talked about 3 of them. The P was? The P was? The D was? And the Q was? Excellent. So we have some side effects you should know. Which one's associated with synchronism? Quinidine. Which one can cause heart failure? Which is associated with lupus-like symptoms or reversible lupus-like syndrome? Procainamide. Excellent. So quinidine can cause synchronism. Disopyramide can cause heart failure. And procainamide is part of the HIPPE mnemonic, HIPPPE, right? Hydralazine, INH, penicillamine, procainamide, phenytoin, and ethosuximide. This is one of those Ps. Reversible lupus-like syndrome via antihistone antibody. So remember it, antihistone antibody, okay? Now, class 1B antiarrhythmics. These are also sodium channel blockers. They also work on fast sodium channels, okay? But these are special, and we'll talk about that in a second. So the mnemonic for this was the Backstreet Boys mainly lack talent. Say it.
Backstreet Boys mainly lack talent.
Excellent. Backstreet Boys mainly lack talent. Mexilatine, lidocaine, tokenide, and then last but not least, phenytoin. Well, these are used best for post-MI situations because the way they work is they preferentially go to ischemic tissue. but they're not going to say ischemic tissue on a test. What they're going to say is one of two things. Already depolarized Purkinje fibers. Already depolarized Purkinje fibers. Say it.
Already depolarized Purkinje fibers.
Excellent. Or activated sodium channels. Say it.
Activated sodium.
So that what they'll say, instead of saying ischemic tissue, they'll describe what makes that tissue ischemic, which is already depolarized Purkinje fibers or activated sodium channels. So that's why we use these in acute situations, especially post-MI and acute ventricular arrhythmias, and also for digitalis-induced arrhythmias. And we'll talk about digitalis and digoxin when we do the cardiac glycosides in a second. Well, here they are, acute ventricular arrhythmias, especially post-MI, as well as digitalis-induced arrhythmias, because these drugs go preferentially to ischemic tissue, aka already depolarized Purkinje fibers or activated sodium channels. And those drugs are mexiletine, lidocaine, tokenide, and phenytoin. Well, out of all those, which one causes severe GI upset? Mexiletine. And if you remember, Mexi for Mexican food. Mexican food gives you GI upset. Mexiletine gives you GI upset. Mexican food is taken orally. Mexiletine is oral. Okay? So mexiletine, oral, can cause a severe GI upset. Which one causes pulmonary fibrosis? Tokenide. So then which one causes a loud S2 sound? Tokenide. And which one causes hirsutism and gingival hyperplasia? Phenytoin. So we have severe GI upset with mexiletine. We have pulmonary fibrosis with tokenide. And we have hirsutism and gingival hyperplasia with phenytoin. Class 1C sodium channel blockers. Well, 1C on mnemonic was Carly is extremely freaking painful. Say it.
Carly is extremely freaking painful.
Right, and our drugs are enconide, flecainide, and propafenone. Now, these drugs are extremely freaking painful because they exhibit zero-order kinetics. That doesn't mean they only exhibit zero-order kinetics, because in order to get to zero order, you must first be at first order. So they just have first-order kinetics for a very short period of time, and they go almost immediately into zero order. And zero order, we know, is no bueno. It's not good. We don't like it. Okay? So we only use these drugs when other drugs have not worked, when arrhythmias are refractory to all other antiarrhythmics, which is why you'll go to this. Because these are your last resort, just like that Call Me Maybe song is the last song I want to hear on the radio. Okay? Carly is extremely freaking painful. Enconide, flecainide, propafenone. Well, there's one thing that you should know about all these drugs, and they do not affect the length of the action potential. Do they affect the length of the action potential? No. Do they affect the length of the action potential? No. Excellent. Well, there's one on this list that's very important, and that one is propafenone. What's the most important one?
Propafenone.
What's the most important one?
Propafenone.
Propafenone, because it's a beta blocker in addition to being a sodium channel blocker. Remember, all the class 1A, 1B, 1C work on sodium channels. But this drug, in addition to working on sodium channels, also blocks your beta receptors. And remember, your beta receptor in your heart, okay, beta 1 will increase heart rate and contractility, so you're going to block it, and beta 2 will affect your contractility more than your heart rate. So propafenone will block sodium channels, and it's a beta blocker, which means that by blocking these beta receptors, which beta receptors, remember, normally increase cyclic AMP because they're sympathetic. When you block it, you're going to decrease cyclic AMP. You're going to decrease cyclic AMP. Okay? These class 1C antiarrhythmics are proarrhythmics. That means they can lead to an arrhythmia. So look at this. You're trying to treat an arrhythmia, and you can actually have an arrhythmia. That's why they don't like using these drugs. That's why these drugs are painful. They're extremely freaking painful for your body. They're not good for you. They go immediately to zero order. Propafenone is the one they like to ask about because it's a sodium channel blocker and a beta blocker. But all three of those drugs are proarrhythmics, which is why they're contraindicated post-MI, because these three drugs will actually increase mortality post-MI. And you don't want to increase mortality post-MI, but you may not have a choice. And remember, you only give a drug that exhibits zero order. If not giving it, it would be worse than having a zero order condition. So if that arrhythmia is so bad and it can't be treated by anything else, you can give them enconide, flecainide, or propafenone. Okay? Cool. So class 2, these are your beta blockers. And we talked about beta blockers in length when we did our ANS lecture, but we'll review them again now. Your beta blockers, okay, they block your beta receptors. Are your beta receptors sympathetic or parasympathetic when stimulated? Sympathetic, cholinergic, or adrenergic? Adrenergic. Your beta 1 receptor increases your heart rate, your contractility. Your beta 1 receptor increases the release of glucagon and renin. Your beta 2 receptor increases contractility, but not necessarily heart rate. It increases insulin, and it increases or causes bronchodilation and vasodilation. Okay? These drugs will block those beta receptors. And everybody in here knows the longest acting beta blocker is propranolol. He's a pro. He doesn't mind working long hours. Remember that propranolol is also used to decrease peripheral conversion of T4 to T3 in thyroid storm. We talk about all the things. That's we're just touching on it again. The shortest acting beta blocker is esmolol. So esmolol will decrease levels of cyclic AMP for only about 15 minutes. Because when you block the beta receptors, you decrease cyclic AMP. Esmolol will only do it for about 15 minutes. And then everybody knows the three that are safe to give in people who have asthma, COPD, or diabetes. Those three drugs that have intrinsic sympathetic action, aka they are partially beta agonistic as well as beta blocking. They're beta antagonistic and agonistic. There's three of them: acebutolol, atenolol, and pindolol. Which three?
Acebutolol, atenolol, and pindolol.
And the reason those three are safe to give in conditions in which normally beta blockers are contraindicated in is because these are partially beta agonists. So they will work in the heart or wherever you want to beta block. But in your bronchioles, they'll still cause that bronchodilation. At your islet beta cells, they'll still cause that release of insulin, which is why acebutolol, atenolol, and pindolol can still be used. Because in addition to beta blocking where you want them to, they beta agonize where you don't want them to block. That's why these three drugs are safe to use. In addition to that, there's two other drugs that are important because these two drugs, in addition to being beta blockers, have alpha-1 antagonistic activities. They have alpha-1 antagonistic activities, and those two drugs are labetalol and carvedilol. Labetalol and? Carvedilol and? Labetalol and? Carvedilol and? Excellent. And those two drugs are used in hypertensive emergencies. But the best drug, remember, for hypertensive emergency is sodium nitroprusside. But we don't like using that drug because it has cyanide in it. It's the only drug in America that has cyanide in it. So if you want to use two beta blockers or a beta blocker for hypertensive emergency, you can use one that blocks your beta receptors and blocks your alpha-1 receptor, and those two drugs are labetalol and carvedilol. The other one you should know is metoprolol. Say it.
Metoprolol.
Because metoprolol can decrease mortality post-MI or in CHF. Metoprolol, ACE inhibitors or ARBs, okay, spironolactone are the three drugs that are known to decrease mortality post-MI and also in CHF. And they're saying you can also use carvedilol, labetalol. But the most important ones I want you to know are metoprolol, ACE inhibitors and ARBs, and spironolactone, okay, can decrease mortality. And then our favorite drug, everybody, is the one that blocks beta receptors and potassium channels. The name of that drug is?
Sotalol.
Sotalol. And so now it's time to sing our song. Everybody repeat after me. Say, sorry, sir.
Sorry, sir.
I gave you Sotalol.
I gave you Sotalol.
So now, you have to stay in the hospital.
You have to stay in the hospital.
Why do you have to stay in the hospital? Because anytime you screw with potassium, you're going to prolong what? Your QT interval, and if you prolong your QT interval, you can lead to an arrhythmia. So if you give somebody Sotalol, the recommendation is to keep them in the hospital and monitor them, and monitor that QT interval, and monitor their rhythm to make sure they don't have a arrhythmia and die on you. And then you'll end up on CNN again. All right? Cool. Well, the mechanism of action of these beta blockers we already talked about. They decrease CAMP. What do they do to CAMP? Decrease. And that's, remember, CAMP is the second messenger for the sympathetic system. So we're decreasing cyclic AMP, and we're decreasing your calcium currents. What are we decreasing? Your calcium currents. Say it.
Calcium current.
Excellent. We're decreasing the slope of phase 4. What phase? 4. So we're decreasing the slope of phase 4, and as a result of all that, we're going to increase your PR interval. What are we going to do to your PR?
Increase.
We're going to increase your PR. We'll use beta blockers for VTAC and SVT, and also to slow the rate and AFib and A-flutter. Okay? So these beta blockers are used for VTAC, SVT, and to slow the rate and AFib and A-flutter. Everybody see a pattern there? Too much beating. It's going too fast. We're slowing it down. Okay? VTAC, too fast. SVT, too fast. And now we're trying to slow the rate, AFib and A-flutter. So for B, just think about you're putting the brakes on. Okay? B for brakes in your heart. Beta blocker, put the brakes on in your heart. Slow things down. VTAC, okay? SVT, and slows the rate. And AFib and A-flutter. Now, class 3 are your potassium channel blockers. There's only two I want you to know. Ibutylide and amiodarone. The reason I want you to know ibutylide is because we said that all the sulfonylureas end in IDE. Well, this ends in IDE, so I don't want you to be confused. This is a potassium channel blocker, ibutylide. And there's another one, amiodarone. And if you look at the screen, you'll see 4 nice big letters in amiodarone, I-O-D-O. Iodo, to let you know it has iodine in it. which is why it has all these bad side effects. So now I'm going to give you the answer. The answer is going to be amiodarone. What's the answer?
Amiodarone.
I'm giving you the answer so you can focus on the question. Which antiarrhythmic can cause hypothyroidism?
Amiodarone.
Which one cause hyperthyroidism? Which one cause corneal deposits? Hepatic necrosis? Pulmonary fibrosis? Turn you blue? Block CP450? Raise levels of warfarin? Raise levels of estrogen? Raise levels of theophylline? Raise levels of digitalis? Excellent. So all these drugs, all these side effects are associated with amiodarone because it has iodine in it. Iodine is not that great for you. That's why it messes with your thyroid, which is why you're going to do a TSH test before administering this drug. You're going to check thyroid levels before administering this drug. Okay? Just remember iodine and you'll get the thyroid questions right. If there's any question on the test about side effects related to antiarrhythmics, and you have no idea what's going on, if amiodarone is on the list, click it and move. Because chances are it causes the side effect that's mentioned, because it causes all of them. Okay? Instead of saying corneal deposits, they may say phototoxicity. Instead of hepatic necrosis, they may say it may eventually lead to liver failure. They're going to change the terms around of the side effects like they always do. Don't change your answer. Okay? They like to use different adjectives, different descriptors for the same terms. Don't fall for the trap. Okay? Amiodarone can turn you blue. Okay? And remember also, going back to our micro lecture, that minocycline could also turn you blue. Okay? So class 3, the way they work is they increase your active potential duration, they increase your ERP, and they increase your QT interval. And that QT interval should make sense because we said anytime you mess with potassium, you prolong your QT interval, you can have an arrhythmia. And the other two, it increases your AP and your ERP. Your AP and your ERP. Your AP and your? Your ERP and your? Excellent. So AP for active potential, ERP for effective refractory period. And here all the side effects are for these potassium channel blockers. Hypothyroidism, hyperthyroidism, hepatic necrosis, corneal clouding or corneal deposits, block CP450, okay? And Smurf syndrome, turning you blue, make you look like a Smurf, okay? Class 4, this is your calcium channel blockers. Your calcium channel blockers. The vasoselective ones end in penes. The cardioselective ones, the ones that are more important, I believe, for this test are going to be diltiazem and verapamil. Diltiazem and? Verapamil. Diltiazem and?
Verapamil.
Hey, one of those two causes very bad constipation. Take a guess, which one is it?
Verapamil.
Verapamil causes very bad constipation. And the reason it causes constipation is because you have constipation when you don't have enough gut motility, when you have decreased gut motility. Well, gastrin uses calcium as a second messenger. So if gastrin cannot work via a second messenger to increase gut motility, and you have decreased gut motility, you can have constipation. So diltiazem and verapamil both lead to constipation, but verapamil will cause more constipation. Okay? The vasoselective ones end in penes. The only one I want you to know is nimodipine. Say nimodipine.
Nimodipine.
Nimodipine is important because it reduces or decreases mortality post-subarachnoid hemorrhage. Somebody the other day said SAW. Don't say SAW. That sounds weird. Subarachnoid hemorrhage. It decreases mortality post-subarachnoid hemorrhage because what it does is it prevents the vasospasm, which causes them to bleed to death after a subarachnoid hemorrhage. So you're going to prevent that vasospasm by causing vasodilation. Okay? The reason and the most correct way to say it is by preventing vasospasm. Not by causing vasodilation, but by preventing vasospasm, if you want to be nitpicky. Nimodipine is that drug. Well, these drugs work by decreasing your conduction velocity, increasing your effective refractory period, your ERP, and your PR interval. Okay? So they increase your ERP and your PR. They increase your ERP and your PR and your
ERP.
but they decrease your conduction velocity, which is why we use them to prevent these nodal arrhythmias. Okay? So these class 4, the side effects of these class 4 antiarrhythmics is constipation. And the explanation as it relates to gastrin is there. It blocks the second messenger for gastrin, which normally increases gut motility, so now you have decreased gut motility. If you're not going to have motility in your gut, you can't get rid of your stuff, you can't poop, you're going to be constipated. Okay? Side effects of constipation, edema, and flushing. Now let's talk about nitroglycerin and isosorbide dinitrate, or nitrates. Well, nitrates cause vasodilation. And what's vasodilation related to? Parasympathetic system or sympathetic system? Parasympathetic. What's the second messenger for the parasympathetic system? Cyclic GMP. So when you see anything that's an antihypertensive agent, whether it's a nitrate or a drug like hydralazine, you're going to pick an answer related to cyclic GMP, whether it be the nitrous oxide part of that cascade or the cyclic GMP part of that cascade. All of these antihypertensives, 9 out of 10 of them, work via cyclic GMP, the parasympathetic system. So these drugs increase cyclic GMP and they dilate your veins before your arteries. Your veins before your arteries. What do they dilate first?
Veins.
Before your
Arteries.
What happens first?
Veins.
Second?
Arteries.
So veins before your arteries, and we use them in angina and pulmonary edema. Now, these nitrates, you cannot give nitrates with Viagra. You're sildenafil. Remember, sildenafil, F for Phil, F for 5, PDE5 inhibitors. Because if you inhibit PDE5 and then give a nitrate, they're going to become so hypotensive they can literally pass out and die on you. So they're going to need to take a break between the Viagra and the nitrate they're taking. Okay? Side effect, reflex tachycardia. Okay? Headache, flushing, hypotension. Okay? Now, we're causing vasodilation. Vasodilation is what causes flushing. Too much vasodilation leads to hypotension, and vasodilation can cause headache. They have nitroglycerin available in the form of ointment, topical nitroglycerin. You better tell your patient to use a glove. If they don't use a glove, it's going to go right through the skin and get into the circulation and cause a splitting headache. Okay? Because headaches are due to vasodilation. Okay? So your patient on a nitrate, tell them, Mr. Patient, when you take this drug, you may have a headache. Okay? Just letting you know. Lay down, relax, take deep breaths. You may have a headache, but it'll pass. Okay? A lot of nitrates are very short-acting. Okay? All right? So make sure they're taking a topical form of this drug for a different condition. Okay? They're going to put a glove on when they apply that to wherever they want to apply it. Okay? Adenosine. And before we talk about adenosine, we're going to talk about opiates and sulfonylureas. Opiates, the goal of opiates is to prevent the signal transduction or prevent the signal transmission of pain. You want to stop pain transmitting from one point to another. You want to stop it in its tracks. So opiates, OP, open potassium channels. How do opiates work?
Open potassium channels.
They do what?
Open potassium
They
channels.
open potassium channels and close calcium channels. Well, when you open potassium channels, that positive charge goes outside your cell. Your cell then becomes more negative. It's less likely to depolarize, and as a result, it's actually hyperpolarized. So the pain signal stops. Exact opposite of sulfonylureas, because sulfonylureas close potassium channels. What do sulfonylureas do?
Close potassium
So we call sulfonylureas because they shut potassium channels. What do? They shut potassium channels. And when you shut that potassium channel, you have more positive charge at your islet beta cell. And then you depolarize and you increase the release of insulin. Okay? So opiates open potassium channels and cause hyperpolarization. Sulfonylureas close potassium channels and cause depolarization. Well, adenosine increases potassium out of your cells. And if you increase potassium out of your cells, are you more or less likely to depolarize? Less likely to depolarize. So adenosine makes you less likely to depolarize. It hyperpolarizes you by kicking potassium out of the cell, which is why we use it in conditions in which we have too many depolarizations, like SVT. Okay? So we use it in SVT because we have too many depolarizations, so we're going to hyperpolarize. Kick potassium out, slow things down. Adenosine, we already talked about. Let's now talk about the side effects of adenosine. Well, adenosine can cause hypotension and flushing, okay? Adenosine is blocked by caffeine and theophylline. Got it? Cool. Magnesium. What does magnesium do? Magnesium gets in the way of sodium, right? And sodium causes depolarization. So we get in the way of sodium, we don't depolarize anymore, which is why we use it for torsades de Pointes. Okay? You go to France, you can say it however you want to, but in America, I'm going to call it torsades de Pointes. Okay? I don't care how they really say it. And also for digoxin-induced arrhythmias. Magnesium gets in the way of sodium, blocks those depolarization. Torsades de Pointes is twisting of your spikes. Okay? Now, here's digoxin. Important drug. Digoxin and digitalis are cardiac glycosides. What kind of drugs are they?
Cardiac glycosides.
Excellent. Well, what these drugs do is they inhibit the sodium, potassium, ATPase. What do they inhibit?
Sodium, potassium, ATP.
Excellent. And then what happens is they indirectly inhibit the sodium-calcium exchange. So calcium gets stuck inside your cell and your contractility goes up. What happens to contractility? It goes up. And so we use it to increase contractility in CHF and AFib. Well, digoxin has some cholinergic effects. Okay, nausea, vomiting, diarrhea, blurred, yellow vision. What kind of vision?
Yellow vision.
What kind of vision?
Yellow vision.
What kind of vision?
Yellow vision.
Yeah, that's my Asians. Blurred yellow vision. What if they say blurred greenish vision? Are you going to pick it?
Yes.
Yes, you will, because yellow is kind of like green. Okay? Don't get confused. Okay? They're going to mess with the colors. They might say it looks like a yellow highlighter. They won't say that. They'll describe something else yellow. Maybe it looks like a lemon. Okay? I don't care what they say. If it looks yellow or kind of green, you're going to pick it. Okay? Don't just stick to exact words you use in the book, because they're not going to use those exact words on the test, because they know that you like to memorize things out of the book, so they're going to screw with you on the test. They're going to change the words around. Now, the important thing about digoxin is what it does to your EKG. So everybody's going to repeat after me, okay? Your PR interval is increased. Your PR interval gets longer. Your PR interval gets longer. But your QT interval gets shortened. What happens to your QT interval? Is it shorter or longer? Shorter. So your PR interval is longer. And your QT interval is shorter. And then you have this T wave inversion and ST segment scooping. ST segment scooping, T wave inversion, PR is longer, QT shorter. And then it causes hyperkalemia. And hyperkalemia is a poor prognostic factor. You better get concerned, which is why for digoxin overdose, the first thing you're going to do is slowly normalize that potassium. And you're going to give Digi-Immune Fab, or digoxin immune fab. What are you going to give?
Digoxin immune fab.
Excellent. That brings us to the end of our cardiac.